we will be talking about acute and chronic complications of cesarean section. We just published this article on the same topic just almost a month back, and this is my wonderful team, and I couldn't have done without them, couldn't have gotten this article published without them. So this is going to be the overview of what we are going to talk about today. We'll talk about the acute complications, and then we'll talk about the delayed or the chronic complications of the C-section. So starting with normal postpartum imaging appearance. Sorry, this is a busy slide, but what I want you to focus on is most of the changes that happen in the myometrium or the uterus, they resolve mostly by 3 weeks. Now let's focus on these two images. That's how the normal uterine appearance looks like. So starting with the sagittal, because we are more familiar with uterus in sagittal plane, either it is ultrasound or CT or MR. So that's the endometrium centrally located, and it's fairly homogeneous. We see this protrusion, which is more triangular, and that's the C-section scar site. And this is nothing but edema, and this is normal appearance. Tiny bits of heterogeneity because of clot or hematoma is also in the expected appearance of normal. There can be a few air foci in the endometrium or in the scar site, and that again is normal. The same thing appears as hypodensity in the lower section and probably looks like a collection, but it is not, because we have to know the clinical scenario, and this is again expected normal appearance. Moving on to acute complications, and like any surgery, the two major complications we would discuss is hematoma formation and infection. So starting with hematoma. So there are multiple different types of hematomas which can happen with cesarean section, starting from where we take this incision, that is the interior abdominal wall, and more specifically in the subcutaneous tissue, within the muscle, behind the muscle, and between bladder and uterus. And we will discuss each type in a bit. So that's what I've been talking about, is the subcutaneous hematoma. Hematoma behind the muscle, but anterior to fascia transversalis, like subfascial. Hematoma within the rectus sheath, or the rectus sheath hematoma, or rectal hematoma. And the hematoma which I was talking about is this hematoma, bladder flap, which is between the bladder and the uterus. So starting with the most common type, which is bladder flap hematoma. This might confuse you because this has nothing to do with bladder. In the sense, like, bladder is not the contributing cause for hematoma. So if we can ignore the hematoma here for a minute, this black line, if you see, is the peritoneal reflection over the bladder going anterior to the uterus. So when lower section LSCS, the cesarean section happens, so the scar is somewhere here, the incision is here. So this flap of peritoneum is reflected off the bladder, and then only we can take an incision here. So this flap of peritoneum is known as bladder flap. And because you're reflecting it, so hematoma formed below it is bladder flap hematoma. So that's the nomenclature. And it has nothing to do with bladder bleeding. This is the most common type. It is confined superiorly by, again, peritoneum. It is, again, in the expected complications. So if it is less than 4 or 5 centimeters, we don't even worry about it because it is known to resolve by its own. But if it is more than 5 centimeters, it raises concern for uterine dehiscence. So that's number one. And let's see how it looks like on imaging. But before I talk about bladder hematoma, again, one more time, we see uterus and we see this edema at the scar site, again, normal. This is uterus in the ultrasound, longitudinal view of the uterus on the ultrasound. So we see this is the normal endometrium. And at the scar site, the endometrium looks more triangular. It is filled with heterogeneous material, which is nothing but hematoma, again, normal. We see this tiny air foci, again, normal. Now let's talk about bladder flap hematoma on imaging. So that's the bladder, that's the uterus, scar site. So hematoma between bladder and uterus, bladder flap. another patient, this is the hematoma between the uterus and bladder flap hematoma. Next type we'll talk about is rectus sheath hematoma. So it is the hematoma essentially happening anterior to the posterior rectus sheath, meaning inside the rectus sheath or within the muscle itself. And the contributing vessels to this is the epigastric vessels, the inferior epigastric ones. So what it will lead to is enlargement of the rectus muscles. So this is the example in which there is bilateral rectus sheath hematoma, right greater than left, and then there is this active extravasation. It's changing its form, and this was embolized. Third type is subfascial, and the fascia here refers to it is behind the rectus sheath itself. So because it is behind, it has free communication with the space anterior and lateral to the bladder, and that space is nothing but space of Retzius, the prevesical space, because it comprises loose connective tissue, a little bit of fat here and there. So up to 2.5 liters of blood can accumulate here. And clinically, it won't be as apparent. The only thing which will be apparent is dropping hemoglobin. Now, a curious question, why do we want to differentiate and tell one type from the other? The most important thing is, let me go back to my slides. So the bladder flap hematoma, if it is large enough, up until 4 or 5 centimeters clinically insignificant and we would do nothing. But if it is like really, really large enough, so to be able to evacuate this, we have to go the same route. We have to actually incise the peritoneum one more time. Versus if it is rectus sheath hematoma, which in this case was just resolved by embolization of the vessel, or if it is the subfascial hematoma, even if this has to be evacuated, the peritoneum will not be entered. And that's the clinical implication that we want to tell our OBGYN colleagues some sense that where the hematoma is happening. So then they can plan accordingly that they do not have to enter the peritoneum. Okay, moving on, the hematomas can get complicated and infection can happen. So this patient has presented 1 month after cesarean section and she had bladder flap hematoma. So this collection was hematoma to begin with. Now it is like an abscess. So again, uterus and bladder, and this is a large bladder flap hematoma that got infected and it's communicating with the anterior abdominal wall. It will become more apparent when I'll play the cine. So one more time, uterus, bladder, collection and between the uterus and bladder, and that's communicating with the anterior abdominal wall. And because this was abscess and needs to be drained, so it was drained under IR guidance. Moving on to a third complication, which is uterine dehiscence. So dehiscence and rupture, they lie along the same spectrum. Dehiscence is when serosa is intact. Rupture is when serosa is also involved. Now, this can be slightly frustrating to us as radiologists because, yes, sometimes we may be able to make the diagnosis, but very often it is a very challenging diagnosis on imaging. But what can be a pointer? We just spoke about the fact that if the bladder flap hematoma is more than 5 centimeters, it can be suggestive of uterine dehiscence. And again, we also have to look into the clinical picture because without clinical picture, it's very difficult to say it is dehiscence or not. I'll show you 2 examples of this. Let's start with the MR example first. So this is T2 weighted imaging, fat sat, sagittal. So we have the uterus here, and then we see a hematoma, a complex fluid anterior to the scar site. We also see this T2 hypointense serosa, which is intact. This image is from literature. So that's how a dehiscence will look like. And if you see, it is mimicking bladder flap hematoma because it is essentially between the uterus and the bladder. This another image, again, was contributed to me by one of my friends. And what we see here is the uterus is, we don't see the entire lining here, but when it was scanned, the uterus was still intact. So this was, again, uterine dehiscence. Couple of inner myometrial layers were not intact, and so was not the endometrium, but the outer myometrial layers and serosa was intact in this case as well. Next comes uterine rupture, as we spoke about the fact that even serosa would be involved. What is the imaging clue here? So the presence of gas. If you remember, I said presence of gas in the endometrium and in the scar is normal. So again, if we see gas in the endometrium and the scar, we have to know the clinical scenario one more time, because that can be normal. That can also tell us it might be a potential rupture. And a third thing, it can be infection, which we'll talk about in a minute. So focusing again on rupture, so presence of gas within the uterine defect, and if it is communicating with the parametrium, plus if there is hemoperitoneum and the right clinical context, will all point towards rupture. So here is the example. So this is axial CT, and we see this is the endometrium hypodense here, and we see hematoma in the endometrium extending into the parametrium. We also see that there is air foci, not shown on this image, but was present in the cases. Air foci were in the endometrium as well, and that air foci were communicating and getting into the parametrium. Again, this can be a normal appearance. So one more time, I would emphasize that we have to know the clinical context. Now, a curious question. When we incise the uterus, we incise mostly in the center. Why the uterine scar is more on the left lateral side? So basically, when the uterus is big, you take the incision, but when the uterus involutes, the incision may not be always in the center, and that again is a normal appearance. So do not expect to see the uterine scar always in the center midline. It can be on the right side a little bit when the uterus involutes, or it can be on the left side as well. Okay, moving on to the next complication, endometritis. Again, endometritis is a clinical diagnosis. What we end up seeing on image is heterogeneous contents of the endometrium and a lot of air. So this appearance, if you show it to me even today, after today's lecture, I would call it probably normal, but correlate clinically if there is signs of infection. And this patient did have indeed signs of infection. The C-section was complicated by chorioamnionitis, and then the patient continued to have high fever and tachycardia. And then patient's pyrexia was to be known, was needed to be attributed to a cause. So imaging was done. Ultrasound showed a lot of gas in the endometrial cavity as well as in the scar, all these dirty foci of air shadowing. And CT also showed the same thing. And the patient was taken to the OR, and DNC was done for the endometrium, for the endometritis. This is another patient. The patient had endometritis, and it went ahead from just being endometritis to formation of pus inside the uterus, pyometra. So this is the uterus endovaginal scan, and we see the uterus in the entirety in the longitudinal section. So I'm tracing the uterus from the outside. So that's the uterus, and that's the distended endometrial canal. And if you see, there is heterogeneous fluid with echoes, which is filling the uterus and distending the endometrial cavity. So this is the longitudinal view of the uterus. This is the transverse view of the uterus, and we see again distended endometrial cavity with heterogeneous contents. And this transverse view is at the level of the C-section scar. So portion of C-section scar is also captured on this image, and we see heterogeneous contents in this as well. Just a CT correlate of this. So again, C-section scar filled with heterogeneous fluid, and this was nothing but pyometra. Also shown on this image is adhesions of the uterus to the anterior abdominal wall, something that we'll talk more about in the chronic complications. Next complication is ovarian vein septic thrombophlebitis. So if there's any inflammation happening in a female pelvis, I always make sure that I look at the gonadal veins, the ovarian veins, more carefully. Ovarian vein septic thrombophlebitis is one of the known complications of cesarean section. And how does it look on imaging? It's better seen on this sagittal view than on this axial, at least on this image. So we see that there is expansion of the ovarian vein. The walls are hyper-enhancing, and the expansion is because of heterogeneous content, mostly low density contents. So this is nothing but septic thrombophlebitis. Also, we see there is some amount of fats running around the vessel, so thrombophlebitis. Usually it is on the right side, but it can also happen bilateral sometimes. So this is another patient who had bilateral thrombophlebitis, right greater than left. So that's the right vessel, and that's the left one. Moving on, retained product of conception. In normal delivery, also we see RPOC in the endometrium. In C-section, we see RPOC. They can happen in the regular endometrium. They can also happen at the scar site. So this is a patient in which there was C-section scar ectopic. Again, something we'll talk about in chronic complication. And patient had been treated medically for the C-section scar ectopic, but there was concern because there was some vaginal bleeding, and when ultrasound was done, there was a echogenic mass at the scar site, and there was a lot of peripheral vascularity. So this is abnormal. CT was done. CT also showed heterogeneous mass and with a lot of vascularity, and a diagnosis of RPOC was made. And because of the patient was bleeding and there was so much vascularity, IR consultation was done. Same patient, and there was a lot of blood from the left uterine artery, and that was subsequently embolized. This is another case. This patient came after 2 weeks of LSCS. She had elevated beta-HCG and paravaginal bleeding. So on this sagittal T2 MR, what we see here is this heterogeneous contents in the lower uterine segment at the expected location of the scar. If you see, there is some amount of T1 hyperintensity. So one of the things which is hyperintense on T1 is blood and blood products. Post-contrast, there was heterogeneous enhancement. And then this patient underwent DNC, and this was nothing but RPOC. Moving on, another set of acute complication. So at times, patients can present with heavy postpartum bleeding, and imaging can reveal a uterine artery pseudoaneurysm, as we see in this case. One important thing which applies to anywhere in the body is if you see arterial venous and delayed phase, more or less the shape is maintained, meaning this is more likely to be a pseudoaneurysm, versus if this was changing shape and form, it will be active bleeding. So those are two different things, and these have to be communicated to the referring provider. And this applies everywhere. So yeah, this was uterine artery pseudoaneurysm. We did not do ultrasound on this patient, but if ultrasound is done, we know the classic Indian sign can be seen. And this was subsequently embolized. So we are done with our acute set of complications. Let's look at the chronic or the delayed complications. That's where radiology has much more role to offer. In acute complications, we offered role for hematoma infection and vascular complications and RPOC, but dehiscence and rupture, we were not very sure because it is always more like clinical thing. But let's see what role radiology has to play when it is delayed complications. So we'll start with uterine scar niche. It has multiple synonyms. It's called isthmocele cesarean section scar defect, uterine diverticulum. So what is this? So uterine scar niche is the area where we take the incision, but not every patient develops it. So the definition is the defect should be at least 2 millimeters in depth, this pink arrow. The other arrows define the myometrial thickness in the adjacent myometrium. So if there is this niche, there will be residual myometrial thickness, which is this green arrow. 2 millimeter or less of this green arrow, which means 2 millimeter or less of this residual myometrial thickness, makes patient more susceptible for uterine rupture in subsequent pregnancies. And this yellow arrow defines its width. Let's see its examples. So these are all three different patients, and endovaginal scan has been done. So this is the uterus, centrally is the endometrium, and we see that this is the C-section niche. It is filled with fluid, and it can be filled with blood products and can cause intermenstrual bleeding. So here it is more elongated. This is patient number 2. Again, we see endometrium, cervical canal, and we see somewhat triangular niche. This patient had somewhat roundish niche and some heterogeneous contents here. The another problem niche can cause is it can be a site for C-section ectopic that we will discuss in a bit. We already discussed that it can cause intermenstrual bleeding. Third thing it can cause is infertility, because the sperm or the semen can just go and deposit more there. So it can also lead to infertility. Does it happen in all patients? No, it does not. So this is what I just spoke about. So we will see that in the form of an example. So, sorry, this arrow is not right. This arrow should extend all the way here. So this is the endometrium. This triangular thing is the niche. So that's its width, depth. This is the depth of residual myometrium. And adjacent myometrium will be extending from here all the way until here. Sorry, this is slightly wrong. Next, we'll talk about abdominal wall endometriosis. It can happen all in the entire area where the scar, where the incision is taken. So it can happen from all the way from the subcutaneous to muscular plane to peritoneum to bladder. And the most common site is subcutaneous, followed by subcutaneous and muscle layers, followed by involving peritoneum, and bladder here is the least common site. One of the diagnostic clues can be cyclical pain at the scar site. The most important pointer that it is C-section scar endometriosis is T1 hyperintensity. But again, that may not be seen always. The other clues can be, let's go to the second case first. Other clues can be either it is T2 very, very dark because of fibrosis, or it can form cysts and there will be fluid levels. So all these are pointers towards scar endometriosis, because it can also have non-specific appearance like this on CT or ultrasound or even on MR. And we might have to throw in some other differentials like desmoid tumor or suture granuloma or even lymphoma. And ultimately, if T1 hyperintensity is not seen, then we might have to resort to doing a biopsy or something. So in this patient, we saw fluid levels and they were T1 really, really bright. Next is scar ectopic. Before even we get into what it looks like and what are the imaging features, the most important thing that I want to talk here is recently in 2022, the nomenclature was changed from CSP, which stands for cesarean scar pregnancy. That has been changed to CSEP, which is cesarean scar ectopic pregnancy. So that's the preferred term now. It's very easy to make the diagnosis on ultrasound, particularly in the first trimester, more so around 6 or 7 weeks. And there are multiple signs, one of which is crossover sign. Let's see what that is. So this is the cervix, internal os. Somewhere here is going to be the fundus. So if you draw an imaginary line from the internal os all the way until the fundus, the gestational sac, if 2/3 or more of it is anterior to this line, that's going to be either low-lying low-lying GSAC or C-section scar ectopic. It can also have differentials like cervical implantation, but cervical implantation is going to be more in the cervix. And it can also be mimicked by spontaneous abortion, but we can always throw in color and see if there is no vascularity. And when we are doing transvaginal scan, we can always see the sliding sign, which is present in spontaneous abortion and not C-section scar ectopic, unless it is also aborting. So let's see how it looks on MR. So starting with this T2 sagittal, so we have the gestation sac in the lower uterine segment. And now comes the importance that we spoke about the fact residual myometrial thickness. So there's hardly any myometrial thickness here. We see this T2 hypointense, just some fibrotic scar here, which is covering the GSAC. The other important thing to note here is that's the cervix. And how do we know it's cervix? So we see the endocervical stroma, which is T2 hypointense. So cervix is not involved and the pregnancy is in the lower uterine segment. Another clue to diagnosis is we see all these T2 fibrotic bands, which is nothing but scar from the prior surgery. If we go slightly more parasagittal, we see more fibrotic scars. And on this axial, it is even clear that this is a post-cesarean case because the left rectus is normally placed, the right rectus, because of the scarring, is pulled. So all these pointers make cesarean section scar ectopic a favored diagnosis here. Let's juxtapose this with cervical ectopic. So we spoke about that the fact that we are seeing the cervical stroma here, which is separate from the GSAC, versus in this second case, this T2 dark cervical stroma, that itself is surrounding the GSAC. So this is cervical ectopic, and that's an important distinction to make. Next, we speak about placenta accreta spectrum. So again, for this, the nomenclature was recently revised. Now it is called as placenta accreta spectrum disorder, PASD, which encompasses accreta, increta, percreta. We need not tell all these separately, but if we are able to, we should or we can. But again, all these are lumped into a single category. So that's how it looks like when the surgeon operates, and you see all these lobules which are just outside the uterus, and that will be replicated on imaging. And one of that signs is placental or uterine bulge and focal exophytic mass. So that's what we will see on imaging as well. Let's see the examples. So that's focal myometrial bulge. That's what I was talking about. Again, because placenta is surrounded by uterus, so its external border should be smooth. It should not be as lobulated as this. So that is itself a pointer that something wrong is going on. The other features of accreta spectrum are placenta is heterogeneous and has T2 dark bands. So these bands also suggest that there is placenta accreta spectrum. Let's see the cine. So this is sagittal, T2-weighted fat sat. Placenta is low-lying, and the entire thing is placenta. But if you see these T2 hypo bands contributing to heterogeneity, so that is again one clue. Second is this bulge, another clue. Again, T2 dark bands, heterogeneity, and a lot of bulges here and there. So this is nothing but a very established or a very clear case of placenta accreta spectrum. Next, what problems the C-section niche can cause is when intrauterine device is placed, the intrauterine device, instead of going all the way until the fundus, can get stuck into that, and that can lead to device failure. So in this patient, the top end of the IUD was at the scar level. That's how it looked on CT, and CT also shows its transverse prongs at the level of the scar. Another complications can be adhesions. Adhesions can be inside the uterus in the endometrium, or adhesions can be outside with the anterior abdominal wall. So we'll talk first about the intrauterine adhesions, something we call as Asherman. And one of the great modalities to detect that is HSG, hysterosalpingogram. So we see multiple filling defects in the uterine or in the endometrial cavity, and these are nothing but adhesions. A different patient, we did saline-infused sonohysterosalpingogram, and we see echogenic bands, again, Asherman. The adhesions can also form with the anterior abdominal wall. So when the adhesions form with the anterior abdominal wall, the cervix gets elongated and uterus is more posterior, meaning it becomes retroflexed and anteverted. And that again is expected appearance after C-section scar. Adhesions can also form around the bladder. And one example of adhesions we saw with the anterior abdominal wall in the case of endometritis. And I think that's probably the last case. And that's about it. I'm open for questions, and I would appreciate if you can scan this QR code for 2 questions to answer. Thank you.
Thank you so much, Yashant, for a very, very, in-depth talk on a very uncommon topic, I would say. Really, really great cases. Since we have finished well in time, we can, I think, take Q&As.
Yeah, absolutely.
So Tanupreet Sethi is asking how to tell active bleeding in uterine pseudoaneurysm.
So active bleeding. So, okay, let's visualize this. Pseudoaneurysm is going to be a sac. Sac will have walls. So if something has walls, everything will maintain its shape, be it arterial phase, venous phase, or delayed. So if you see that glob of contrast, which is maintaining its shape, that is going to be pseudoaneurysm. If the shape is not maintained, if you see diffuse scattering of contrast, which changes its shape from phase to phase, that is active bleed. Does that answer your question?
I think it does. This is an anonymous question. Differentiating between scar niche and dehiscence.
That's a very good question. Again, on imaging, that's not possible. It will always be a clinical diagnosis. If you see if you do an MR and if you see the serosa, which is the hypointense T2 hypointense Raymer line, which I showed you, then you can say it is dehiscence. But if you don't see that, then it is difficult to say it is niche versus dehiscence.
Okay. If CA endometrium extends to the uterine niche, does it have implications? This is Anita's question.
That's a very good question. Again, I have not read it, but intuitively, yes, because that might lead to faster parametrial invasion. I have not read it, but I think intuitively that's what I would feel, that it will lead to faster parametrial invasion.
How to differentiate AVM and RPOC on ultrasound confidently?
Okay, that's again a very good question. So first you have to localize endometrium. RPOC is going to be endometrial process. So if you see, let's talk about non-vascular RPOC first. So RPOC can be non-vascular or vascular, meaning if you see uterine endometrial thickness more than 1 centimeter without vascularity, that again is RPOC. If you see endometrium, which is not 1 centimeter but shows vascularity, that also is RPOC. So meaning RPOC is endometrial based thing. Versus if you say AVM, that's going to be more myometrial thing. So you have to define, like, on ultrasound, you very well see that the limit of endometrium. So if something is happening outside endometrium, meaning in the myometrium, that's going to be AVM. The second thing here is uterine AVM is very, very rare. Primary is extremely uncommon. Secondary, which happens after, say, C-section or after, like, a vigorous DNC, that again is very uncommon. But when it happens, it's going to be more like a myometrial process. Yeah.
Okay, an anonymous attendee is requesting you to show the late complication overview slide again. I think they may want to just have a look at it. Bethlehem is
Sure.
asking, patients usually complain of lower abdominal or pelvic pain years after the cesarean section. Is it related to the C-section? Is there any chronic complication associated with C-sections?
I'm sorry. I mean, cause of pain after cesarean section multiple years later. No, I'm not sure if I know of any cause.
So probably maybe not related. So there's no defined cause then. Got it. Anu's asking, do RPOCs enhance on the post-contrast MR?
They can, yes. Yes.
Okay, Sumanta is asking, difference between dehiscence and rupture. How do you differentiate between the two?
Again, very good question. Unfortunately and frustratingly enough, on imaging, we cannot always differentiate. Say, suppose if you perform MR and if you see the serosa is intact, which means it's dehiscence. If serosa is not intact, it is rupture. But that's always not possible. Even on MR, it can be like, slightly not very clear. But we have some imaging clues, like if there is hematoma, like we spoke about, bladder flap hematoma more than 5 centimeter points more towards dehiscence, versus in the right clinical context. Not every bladder flap hematoma more than 5 centimeters dehiscence, but bladder flap hematoma more than 5 centimeter in the right clinical context is dehiscence, versus air in the endometrium extending into the parametrium, along with hematomas here and there and hemoperitoneum in the right clinical context is rupture. And 1 second, I'll just show you again so that it just registers in your brain better. So we saw this example and there was air. It's not seen in this picture, but there was air in the endometrium, air extending into the parametrium, and there is hematoma. There was hemoperitoneum. In the right clinical context, this points towards, this is not rupture, this points towards rupture, which was proven by the clinicians, like intraoperatively, that was proven. Similarly, dehiscence, if you see, if there's a large bladder flap hematoma, that in the right clinical context points towards, it's not dehiscence, it points towards. Unless if you have a very good quality MR and you see T2 hypointense serosa, only then can you say that it is dehiscence.
Okay, anonymous attendee is asking to explain how to differentiate a C-section ectopic versus, or rather C-scar ectopic versus low-lying GSAC.
Okay, so first of all, C-section ectopic, if you put color, it's going to show like, the trophoblastic reaction because it still has that thing. Versus if it is, you said aborting sac, right? What do you have to differentiate?
Lower uterine GSAC.
Viable, okay. That will be a difficult diagnosis. That will be a difficult call to make.
Got it. Bethlehem is asking you, so she's asking the pathology or the physiology behind scar niche causing infertility.
So what happens is that's the so one complication of scar niche is intermenstrual bleeding. Why? Because it's a reservoir. It's a space where the blood can fill in. Similarly, that space can fill up the sperm or the semen. So that is a proposed mechanism. We don't know if it is true, but that's a postulated mechanism for it to cause infertility.
Got it. Another anonymous question is asking, can we differentiate the different spectrum of placenta accreta, increta, percreta, etc.?
Not always. See, if it is frank invasion of adjacent structure, like the example that I showed you, or if it is frankly invading the bladder or the vessels around, then yes, it is percreta. But otherwise, it's very difficult, and that's also one of the reasons that all these classes were merged as PASD, like the entire spectrum disorder. That's why it is called spectrum disorder, because it was difficult to differentiate in every case.
Got it. So, a number of anonymous attendees are asking, basically differentiating post-abortion hyper, post-operation hypervascularity from pseudoaneurysm, from AVM, etc. So I think this is what
Okay,
people are clearly still confused about. So if you can elaborate on that.
sure. So, starting with the pseudoaneurysm, because it's got a wall, so it will contain the contents, and what it is containing is blood. So it will always form or maintain its shape. If it loses its shape, it becomes active bleeding. The one thing which I did not speak about today is enhanced myometrial vascularity, because I didn't want to confuse you with that. So it's a recently described thing in which the uterus shows increased vascularity as a response to pregnancy. That does not contribute to bleeding, and that resolves by 8 to 10 weeks. That's not like as focal as this can be, but that is usually not as focal as this and clinically not as apparent. So that's enhanced myometrial vascularity. This is pseudoaneurysm. Active bleed will change its shape. RPOC will be more myometrial based, and all these three will be more, sorry, RPOC will be more endometrial based, and all these three will be more myometrial based.
Got it. That I think was very useful. So, one question is on residual myometrial thickness criteria for uterine niche.
Mhm.
What is the thickness that predisposes to rupture?
I mean, again, if you read a lot of literature, they say 1.5 to 2 millimeters. And at my center, we do not measure this. So I really don't know how academic this is. But what is quoted in literature is if it is 1.5 to 2 millimeters, meaning like if it is less than 2 millimeters, it definitely predisposes to like increases chances of rupture, uterine rupture in the subsequent pregnancy.
Got it. And the scar thickness, as we can see from the diagram, because this was another question, is very well defined as the pink arrow, right? The depth, when they ask on ultrasound to ask, what is the scar thickness, what is the measurement would you give? Is it the
Scar,
green arrow?
scar thickness is green.
The green
Pink
arrow.
is like pink is just the depth of niche. Basically, if it is not 2 millimeter, it's not even called niche. That's what I'm trying to say. So both are twos. Like if you want to remember it easily, pink is two, green is two, but scar thickness is going to be the green, which is nothing but residual myometrial thickness.
Got it. Okay, often when patients come to differentiate between RPOC and AVM on ultrasound, do you use the Doppler or the RI? Does that help? That is one of the questions.
Uh, we need to have Doppler because Doppler only will tell you if there is vascularity or not. So Doppler, if the vascularity, the epicenter is in the endometrium, it is RPOC. If the epicenter is in the myometrium, it is going to be AVM. And again, uterine AVM, as I said, like are really, really uncommon. I have myself not seen more than 5 or 6 cases in last so many years. So expect more of, if you're seeing vascularity, expect more of RPOCs, but make sure that it is all within the endometrium.
I agree. I think it was one of the most overcalled, diagnoses that we used to give in during our residency, at least. Okay, how to define the captive corpus syndrome?
I'm sorry, I don't think I know that.
Okay. Yeah, I mean, I've also heard this for the first time. Very interesting.
Captive corpus syndrome.
Captive corpus syndrome. This is by an anonymous attendee. Maybe you can, who has asked this question, if you can type more details on what exactly are you talking about. Another question by an anonymous attendee: how to identify infection in a flap hematoma?
So radiology can point towards infection, but always not be true in that sense. So one of the things that we talk about, again, infection anywhere in the body, head to toe, if you see presence of gas, so that can be one pointer. Second thing is hematomas are more hyperdense on CT. If you see hematomas with a well-defined, like an abscess, with a well-defined wall which is enhancing, so that is another pointer. Third thing is between the stage of having a well-defined wall and being slightly loose, so there will be a lot of stranding around it, more than what you expect. So a lot of stranding, inflammatory stranding, or presence of gas, or formation of a very well-defined wall, meaning it has turned into an abscess. So those could be a few pointers that this is infected. But again, the reason imaging is done because the patient presented to the provider and they have seen there is fever, there is tachycardia, and all those signs. So all these have to be always integrated. So this is what I was trying to show you. So if you see this example here, so we saw bladder flap hematoma, which was heterogeneously hyperdense because blood will be hyperdense here. But this patient who presented 1 month later, it is almost all liquefied, meaning it is all homogeneously hypo, has got thick, very well-defined wall, a lot of inflammatory stranding around it. So all these are pointers. And if there was any gas without its communication either with bowel or with exterior, that also is an indicator that there is infection.
Got it. So, one question by an anonymous attendee is, below what scar thickness would you say that there is increased risk of dehiscence?
Not for scar thickness. Like, are they asking just for